Hello, my dear friends. Welcome to the Daily Dose. I am myself Dr. Rajesh Gubba. I am a cardiologist and I am also the mentor for teaching general medicine in exams like NEET PG, JIPMER, and as well as AIIMS. So, as a part of the today's Daily Dose, I have a 56-year-old man presents to the clinic with symptoms of exertional chest tightness, which is relieved by rest. And you have requested an ECG which reveals that patient has first degree heart block. Which of the following ECG abnormalities is typically seen in first degree heart block? The options are PR interval more than 120 milliseconds, PR interval more than 300 milliseconds, PR interval less than 200 milliseconds, PR interval more than 200 milliseconds, PR interval less than 120 milliseconds. So this particular question is basically on the explanation about the PR interval. So first of all, you should know what does the PR interval represents. Okay. So if you see this PR interval, the PR interval on the ECG, it starts from the starting of your P wave to the start of the QRS interval. Right, start of the P wave to the start of the QRS interval is the PR interval. And how much is the duration of this particular PR interval? That is around 120 to 200 milliseconds. That is 0.1 to 0.2 seconds. That is a normal PR interval. Now, what does this PR interval represents? PR interval, it represents the time taken for the impulse to move from SA node to the AV node and as well as through the AV node. That is what the PR interval represents. Now, in certain clinical conditions, the PR interval is prolonged, and in certain clinical conditions, the PR interval is shortened. Now, let me discuss the conditions where the PR interval is prolonged. So, if you take the conditions where the PR interval is prolonged, that is, or the PR interval is variable, that is, in first degree, second degree, and as well as the third degree heart block. Right, so you take the first degree heart block. So what is this first degree heart block represented by? The first degree heart block in the ECG, it is represented by the prolonged PR interval. And how much is that particular prolonged PR interval? That is greater than 0.2 seconds. Okay, so that is greater than 200 milliseconds. Alright, so now you take in this ECG. So this is the PR interval. So it starts from here up to here is your PR interval. So if you take the PR interval at this in this ECG, that is nearly around 280 milliseconds. Right? So that means the PR interval is more than 200 milliseconds, which is suggestive of the first degree heart block. Next, now let me tell you about the second degree AV block. So if you take the second degree AV block, like it is again of two types. One, Mobitz type 1 second degree AV block, Mobitz type 2 second degree AV block. Mobitz type 1 second degree AV block, the other name given to that is also called as Wenckebach's phenomenon. Now, in case of your Mobitz type 1 or Wenckebach's phenomenon, what will be the ECG finding? The ECG finding is that there will be progressive PR interval. Right, from complex to complex, the PR interval length, it increases. So there will be progression of the PR interval followed by non-conducted P wave. Right, followed by non-conducted P wave. Let me show you that in the ECG. So you take the PR interval at this point. Compared to this particular complex, you take the PR interval in this complex, it is prolonged. And compared to this complex, if you take the PR interval here, it is further prolonged. And followed by that, you see this is a P wave. And you don't have the QRS complex. That is nothing but your non-conducted P wave. So, in Mobitz type 1, there will be progressive prolongation of the PR interval followed by a non-conducted P wave. That is nothing but Wenckebach's phenomenon. Whereas you take Mobitz type 2 AV block. In case of Mobitz type 2 AV block, the PR interval, it remains constant. Right, PR interval, it remains constant in case of Mobitz type 2. But what you will have a non-conducted P wave intermittently. You see this is the P wave and you don't have the QRS complex. So that is your Mobitz type 2 AV block. So in second degree AV block, these are the two subtypes, Mobitz type 1 and Mobitz type 2. Now, you take this particular ECG. This particular ECG is of the Mobitz type 1, right? So what did we study in Mobitz type 1? Like we have seen that like the PR interval progressively increases. So if you see these complexes, like the PR interval, okay, it is progressively increasing. You can see here, this is a P wave here, right? This is the P wave. And here you have a P wave and there is no conducted P wave, right? That means there is no QRS complex, which is suggestive of Mobitz type 1 AV block. Now you take third degree AV block. Third degree AV block, this is nothing but your complete heart block. So in complete heart block, the P wave and as well as the QRS interval, they don't have any particular correlation, right? So you see, I'll just show you an example. You have a P wave and you have a certain PR interval and you have the QRS complex and then P wave. Then you have a P wave and you take the PR interval. It is not at all correlating with the previous complex PR interval. And you have the T wave. Then again you have the P wave and again you see the PR interval is grossly prolonged. Then you have a T wave. Then again you have a P wave and there is no QRS complex. You have a P wave, and there is no QRS complex. So in case of third degree AV block, what I want to tell you is there is no correlation between the atrial and as well as ventricular contraction. Atria will contract on its own and as well as ventricle will contract on its own, right? And immediate treatment of choice for third degree AV block is you need to put the temporary pacemaker insertion. And if it is a reversible causes, then you try to reverse that particular cause. Like for example, what are the reversible causes? Like you take in patients like hyperkalemia, they can present with the complete heart block, right? And you try to correct that particular hyperkalemia, then the third degree heart block can get corrected. But whereas like you take permanent cause, like for example there is an SA nodal degeneration or AV nodal degeneration, right? It's a permanent block. So in such case the individual will require permanent pacemaker. So these are the conditions where you have prolonged PR interval. And the condition where the PR interval will be shortened, right? That means the PR interval is less than 120 milliseconds. You will have that in patients with what is called WPW syndrome, that is Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome, this is one of the pre-excitation pathways, or it is your pre-excitation syndromes. Now, apart from your anterior, middle and posterior internodal fibers between SA node and AV node, in Wolff-Parkinson-White syndrome, there is an accessory bundle. And the name of that particular accessory bundle or accessory pathway is the bundle of Kent. And because of this particular accessory pathway, the impulse from atria to the ventricle will also go through this accessory pathway, and that is the reason why the PR interval will be shortened. So if you see here, this is your PR interval, right? And you can make out that the PR interval here, it is less than 120 milliseconds, right? So where is your P wave? This is your P wave, right? And this is your, yeah, so yes, up to here is your the starting of the QRS complex. So if you take this, this is less than 120 milliseconds. And the peculiar wave like what you have in WPW syndrome is your delta wave, right? So this is your delta wave. The arrow is representing your delta wave. Okay, so going back to our question now. So the ECG shows first degree heart block. So what should be the PR interval? The PR interval should be more than 200 milliseconds, right? So my dear friends, this particular video is completely on the PR interval, right? I hope you might have liked this particular video. Please follow us on the daily dose. Thank you very much.